Sir, we are licensed.
Good afternoon, everyone. So we have gathered here to observe the World Stroke Day 2024. Today is another auspicious day as per our calendar, that is Dhanteras. So from the project Healthy Food for All, we wish you all a happy, prosperous New Year and a happy Dhanteras and Diwali. For today's session, we have a stalwart among ourselves, Dr. Professor Prashant P. Joshi, sir, who is the Executive Director of All India Institute of Medical Sciences, Nagpur. He is a very renowned clinician, and he did his masters in epidemiology, and he would be one of our keynote speaker for today's occasion. So we would be going live to sir. Over to you, sir.
Good afternoon, friends. Welcome for this program on World Stroke Day. World Stroke Day is observed every 29th of October every year. And this time it is related to sports and physical activity. Can we go to the next slide, please? So basically, heart attacks and paralytic strokes are increasing in India with an escalating epidemic. India has witnessed a dramatic rise in cardiovascular diseases in the last few decades, and it is going to increase in future as well. The epidemic is essentially driven by lifestyle factors, lifestyle changes, and there has been a dramatic change in which we are living now as compared to what our lifestyle was a few decades ago. We have started adopting risky behaviors characterized by a diet which is atherogenic and thrombogenic, excessive use of inexpensive tobacco, lack of physical activity, lack of exercise leading to obesity, lack of consumption of fruits and vegetables, increased consumption of high fatty food, which is dense in calories and less in nutrition. And this has led to an increase in prevalence of hypertension, diabetes, and dyslipidemia would lead to cardiovascular diseases like heart attacks and paralytic strokes. One of the important characteristics about the cardiovascular epidemic in India is that heart attacks as well as paralytic strokes occur a decade earlier in Asians as compared to the rest of the world. In addition to that, we have found that the deaths due to cardiovascular disease also occur a decade earlier. Diabetes, onset of type 2 diabetes also occurs a decade earlier in Indians as compared to rest of the world. And all these risk factors are increasing in India, essentially driven by lifestyle changes. And also, these risk factors operate at a lower cutoff levels. Hence, we have different cutoff levels for defining obesity in South Asians, in Indians as compared to Western population. For defining obesity, we have a BMI cutoff level of 25, whereas in Western countries it is 30. So with different cutoff levels for abdominal obesity, which is less, it is not. It is 104 in centimeters of waist circumference in Western in males, as 88 in females, but in Indians it is 90 centimeters and 80 centimeters in males and 80 centimeters in females. So why the cutoff levels are lower in South Asians is because these risk factors operate at a lower cutoff levels. And therefore, this epidemic in India is in fact interventions which would prevent heart attacks as well as paralytic strokes should start earlier in the South Asians because the risks start early in life. Next slide. So the theme of this World Stroke Day is harnessing the emotional power of sport to prevent stroke. And this is on stroke prevention, leveraging the emotional power of stroke to raise awareness about stroke, encourage action on stroke prevention and rehabilitation is the theme of this year's World Stroke Day. Next slide. So these are 10 risk factors study conducted they called the Interstroke study, in which Salim Yusuf was the principal investigator, conducted and also we also were part of this study, which actually showed that these 9 risk factors accounted for 90% of paralytic strokes, not only in Asians and in but also worldwide. The most important risk factor is hypertension, followed by smoke, and the population attributable risks of both ischemic as well as hemorrhagic strokes are depicted here. Again, physical inactivity, consumption of atherogenic diet, high waist, abdominal obesity, smoking, high alcohol intake, psychosocial stress, and there is a cardioembolic stroke, which is for ischemic strokes, and of course, dyslipidemia, characterized by a high ApoB by A ratio. Next one. Similarly, this is very similar to what was the INTERS-HEART study, which again showed that 9 easily measurable, potentially preventable risk factors accounted for 90% of heart attacks and heart attacks occurred a decade earlier in Indians. In India, first heart attack, the mean age was 53 years, whereas in Western population, developed countries, it was 63 years, and the rest of the world, it was 58 years. So heart attacks also occur a decade earlier in South Asians. Then this was determined by this, very clearly demonstrated by this inter-heart study, which actually was conducted in 272 centers in all inhabited continents except the Antarctica. Next one. Next slide.
It's not changing.
So basically, there has been, we need to change our lifestyle and also consumption of a diet which is healthy. And AIIMS Rishikesh is implementing the healthy food for all, which aims to combat hypertension and associated health risks like obesity, cardiovascular disease, and diabetes. And also, can you get the next slide? Presenter.
That's not changing. So
It has got stuck.
yes, this
The theme of this year is physical activity, and there are a lot of advantages of exercise, which makes you fit, and it decreases the. So basically, there are a lot of advantages of exercise. It helps to decrease the blood pressure, helps to control blood pressure, control diabetes, control dyslipidemia, prevent hypertension, diabetes, heart attacks, and strokes. And it helps not only as a cardiovascular benefit, but it also causes release of endorphins, and that decreases stress, and helps to build bones, muscles, and makes the heart and the blood vessels strong. So exercise is a very important intervention to prevent strokes. So participation in sports for prevention of participation in sports to prevent strokes, and a meta-analysis actually showed that it is very beneficial and to prevent strokes. Can we have the next slide? And recent participation in strokes were associated with the reduced odds of developing strokes or TIA. Next one. And even half an hour exercising every day of walking, or more than 1 hour per day walking, had a 17% to 33% lower risk of age-adjusted risk of developing of stroke. Therefore, mortality from stroke. Therefore, exercise actually or walking simply helps in reducing the mortality due to stroke. Next. Not only ischemic strokes, but also hemorrhagic strokes as well. Not only strokes helps in is prevented by exercise, but also after development of strokes, it helps in stroke rehabilitation to improve the heart functions, cognitive functions, and improve your body composition. Next one. Fit India movement, which was launched on August 29, 2019. The movements, include making fitness fun, easy and free, raising awareness about fitness and physical activities, promoting indigenous sports, making fitness accessible to schools, colleges, and villages. Next one. And the National Education Policy 2020 integrated sports learning to be undertaken in the classrooms in schools. So we have to start and catch them young when they are going to schools itself, and adopt fitness as a lifelong and a life course approach needs from womb to tomb is something which needs to be adopted to prevent cardiovascular disease and achieve the related life skills along with levels of fitness. Next one. So maintaining healthy lifestyle, and therefore the 9 risk factors which I just enumerated for which were responsible for 90% of strokes, which are essentially driven by lifestyle. If you maintain lifestyle, we can prevent 90% of strokes. Avoiding smoking, avoiding alcohol, regular physical activity, dietary modifications of limiting sodium, limiting red meat, limiting sweets, and high calorie dense food. We need, and regular health checkups are very important. Now, very important is it's in the public message which needs to be sent is what is known as Be Fast. B stands for that helps the public in identifying the early onset at an early stage of development of strokes, so that they can seek medical attention immediately. Now we know that thrombolytic therapy, if it is given within 4.5 hours after the onset of stroke, and we need to do a CT scan also to rule out bleed, and thrombolytic therapy would actually save lives and make good recovery after stroke. And therefore, it is essential that the patients who are developing stroke, they report to the center where thrombolytic therapy is given at the earliest possible. And for this message should be circulated to the general public so that they can identify the early stage of stroke and report to a proper healthcare center where thrombolytic therapy is available. And for that, we have an acronym called Be Fast. B stands for balance. That is when a person develops imbalance while walking. That indicates posterior circulation stroke. E is eye problems or diplopia, and that again indicative of posterior circulation stroke. And Be Fast, F stands for, so this is an acronym, Be Fast. Fast means F stands for facial asymmetry, drooping of the face on one side, indicating facial palsy. A stands for weakness of arms, speech disturbances, slurring of speech, and T stands for time. Therefore, a person who is developing these symptoms needs to report to a hospital where CT scan can be done and thrombolytic therapy can be started within 4.5 hours. Then we can help to improve the prognosis and improve outcomes in patients who develop stroke. So World Stroke Day, therefore, emphasizes and helps and on sports to prevent strokes. And this is the main message which is important, which needs to be spread to the general population. Thank you very much for a patient listening.
Thank you very much, sir, for your keynote address and the guidance which you have provided to the upcoming and budding physicians on the occasion of World Stroke Day. Sir, I would like to tell you that around 50 participants have joined us through virtual platform on YouTube, and they belong to various institutes, including AIIMS Nagpur, AIIMS Gorakhpur, AIIMS Jodhpur, BHU Varanasi, GMC Mumbai, that is Grant Medical College, and some of the other good institutes across India. It was actually a privilege to hear from you, sir, who is very well known physician in the field, and we thank you all for addressing the entire audience. Now, dear attendees, we would be moving to our next session, which would be presented by our first technical expert, Professor Pradeep Deshmukh, sir. Sir is Dean Research as well as Head of Department of Community Medicine at All India Institute of Medical Sciences. And sir doesn't require any introduction as such. But so over to you, sir.
Thank you, Yogesh. At the outset, let me thank AIIMS Rishikesh, our director of AIIMS Nagpur, Dr. Joshi, Dr. Pradeep Agarwal, who is the PI for the Healthy Food for All project under which this activity is being conducted, for giving me opportunity to speak on this World Stroke Day on the topic of accelerating hypertension care in healthcare settings. Next, please. We all know stroke is a leading cause of mortality and disability worldwide. WHO have estimated that approximately 11% of the deaths, of overall deaths, are attributed to stroke, and that places it to the second leading cause of death globally. Next, please. The global study estimated that over 6.6 million deaths and 143 million disability adjusted life years in 2000 study are due to stroke. And 75% of this burden comes from low and middle income countries. Next. This is a map of incidence of stroke, and you can see the dark blue colors, they have the list incidence, while the red and dark reds has the highest prevalence, and India comes somewhere in the middle of this spectrum. Next, please. The incidence in India is in the range of 120 to 145 per 100,000 population annually, and that takes it to the fourth leading cause of death and the fifth leading cause of disability in the country. Next, please. If you see this diagram, what we see in this diagram is like the access to services, the capacity of the service provision has remained over a period of say last 2.5 decades. And but the NCD care, access to NCD care has improved over this decade. And if you look at the incidence, that is the blue line, that tells us that incidence has gone up a bit. The deaths due to stroke has gone down. But if you look at the disability adjusted life years lost due to stroke, so that tells us, though we are, because of improved access to the healthcare, the deaths due to stroke has come down. But since the incidence is going up, the disabilities, the people are living with disabilities, and that is not a good sign. So that takes us to the importance of prevention of strokes. Professor Joshi has already enumerated the risk factors for strokes and the importance of hypertension as an important risk factor. And sir has given the figures that for ischemic stroke, the population attributable risk is around 45%, and for hemorrhagic stroke, it is 75%. That means if the hypertension is removed from the population, we can like almost half of the ischemic strokes and 2/3 of the 3/4 of the hemorrhagic stroke. Next, please. High blood pressure is a risk factor not just for the stroke, but other diseases like CHDs, congestive heart failure, impaired renal failure function. And if you compare the diastolic blood pressure of 75 mmHg as against 5 mmHg, there is a 10-fold increase in the risk of stroke. And prolonged reduction of diastolic blood pressure by 5 mmHg will reduce the stroke incidence by 34%. 2 mmHg population-wide decrease in systolic blood pressure in India can prevent 150,000 coronary artery diseases and 150,000 deaths stroke. So we can prevent just by decreasing 2 mmHg of systolic blood pressure, we can prevent 300,000 deaths in the country. Next, please. Next, please. This is the data from NFHS 5, and it tells about the prevalence of hypertension in our country. It is around 24%. If you see the rural-urban divide, it is not much difference. Male, female have a higher prevalence as compared to males. Next, please. This diagram also tells you that initially, a decade early, we used to talk about that the prevalence of hypertension is high among the urban population as compared to rural population. But this tells us that how over the decade, the gap has narrowed down. Though the prevalence ranges from 8% in Kerala to around 24% in say some states like Assam and Sikkim, where the tobacco use is quite prevalent, the gap, urban and rural, has narrowed down. Next, please. This is a small study that I conducted in Wardha, and it tells you about the, this was a decade and a half back. And it tells you about how the prevalence of hypertension increases with age. Even the adolescents had prevalence of around 3.5% sustained, that is the sustained hypertension. Important point here is, if you consider 120 mmHg and 90 mmHg of diastolic blood pressure as normal, then about 2/3 of the population, adult population, had blood pressure more than normal. That is alarming. So there are it has been estimated that around 200 million individuals in India are currently hypertensive, and only 1/10 of them are under control. Contributes to 1.5 million deaths by ischemic heart disease and the stroke. So there has been initiatives taken by Government of India for prevention and control of hypertension. So there is a national program for prevention and control of non-communicable diseases, which was launched in 2010. The earlier name was different. Now it is called National Program for NCD. There is, in 2017, government has launched India Hypertension Control Initiative, and in 2023, a new initiative called 7525 has been launched. So in National Program for Non-Communicable Diseases, it has been now implemented the countrywide, and there is a system of population-based screening. Then the referral of the screened people who are at high risk of hypertension, they are referred to the primary health center. They are put on the drugs and referred to health and wellness center for the treatment, which is managed by the CHO, community health officer. That is the system, but there are issues in this system. Though on paper the program is very robust, we implemented one project of for the control of hypertension in one of the blocks of Nagpur, and the issue as we started screening and referring the people and putting the people on the treatment, the drugs uh, was exhausted in 3 months' time. The whole year's stock was exhausted in 3 months' time, and the rest of the time there were no drugs available. In around 6 months back, I was sitting at health and wellness clinic where the CHO was telling me about a patient. That patient was present there. So he was telling me that almost 15 days back, he was discharged from the AIIMS Nagpur, and he was admitted for diabetic ketoacidosis. The CHO gave him 5 tablets of metformin, and I advised him to take 1 tablet per day. So I asked him, like, he is like recently discharged patient of diabetic ketoacidosis. Then you just prescribe 1 tablet per day. So he told me that the drugs are not available, and he has to manage or ration the drugs. So next, please. The another initiative was India Hypertension Control Initiative. This was launched in 2017. In a phase one, there were 5 states. It was implemented in states in 26 districts. Wardha district was one of the district under this phase one. And then by 2021, more than 100 districts across 19 states that have been covered. So government came up with 25 by 25 goal, which aims to reduce premature due to NCDs by 25% by 2025, and reduce the prevalence of high blood pressure by 25% by 2025. But there are issues to achieve this. This initiative has 5 key strategies. Like, one is standard treatment protocols, then uninterrupted supply of medicines, task shifting and team-based care. In that, in this program, the screening is done by the ASHA, the treatment initiation is done by primary health center medical officer, and for continuation of the treatment, the patient is referred to health and wellness center where the CHO manages. That is what is the team-based care, the task shifting. Then MIS, the good information system have been developed, and the patient-centered care. These are key strategies under this ISCI initiative. Next. In 23, government also added this new initiative of 75 by 25. So under this initiative, government targets to screen and place 75 million people with hypertension on standard care by 2025 through primary health centers. And the strategy remains the same, that is the health cadre and the building the capacity. Next. So mainly as clinicians, we focus on patients with high levels of blood pressure. And this is a high risk approach for hypertension control. So if you see at higher levels of blood pressure, they have a higher risk of complications and the death. And at lower level, the risk of complications and the death is very low. And that takes us to high risk approach. So we will treat only those who have the high blood pressure levels. And that's why in the program, the prevention strategies has not taken much. They lack So, but what happens here, at higher blood pressure levels, the population is very less. Though the risk is high, the population is very less. At lower levels of blood pressure, though the risk of complications and death is very less, the population is very high. And that's why what happens, next please. The excess deaths happen at lower levels of blood pressure and not at the higher level of blood pressure. And this demands the population-based approach for hypertension control. Next, please. So what are the recommended population-based strategies? So one important is leadership. Here we want to prioritize hypertension control and facilitate adequate resource allocation, and the program is separate from this. Screening and outreach activities. We have to identify and make every opportunity to screen a person for hypertension. That should be implemented. Then we need to implement the treatment protocols. Simple and standardized treatment protocols should be available, and every manpower who is working on this should be trained. Next, please. Medications, they should be available, affordable medicines at low cost or the no cost should be available, because this is a lifelong medication is needed, and any medications are not available, the complications happen, then catastrophic expenditure is can happen to this family. Then monitoring and reporting, so that the data is based on data, we can plan future interventions. And task sharing, because the manpower is always a crunch. So task sharing is again important. Next, please. So what is the way forward? We need to strengthen our health system. We need infrastructure, human resources, drug supply, so that we can take up this humongous challenge, like managing, say, 25% of the adult population who have hypertension, or managing 66% population who have more than normal blood pressure is a humongous. For that, we need a strong health system. Then we need to shift from high-risk approach to population-based approach, as discussed in the risk pyramid concept. Then digital health initiatives for diagnosis and monitoring may reduce the burden and facilitate the program implementation. And also we need to take up implementation research, how we can take care of NCDs. Next, please. So these are the references. Next, please. Next, please. Thank you.
Thank you very much, sir, for enlightening our audience with a very superb talk and telling us that if we manage hypertension and prevent the complications of hypertension, eventually we would be able to prevent the incidence of stroke among our population. Audiences are requested to kindly submit or put their questions into the chat box on YouTube. We would be taking the questions one by one once all our technical sessions are over. With this, I'm introducing our another expert on the field, Dr. Ashutosh Tiwari, sir. Sir is Associate Professor in the Department of Neurology at All India Institute of Medical Sciences, Gorakhpur. And sir has various research articles to his credit on stroke. Also, I know sir, because sir was working on population-based stroke registry. And with a small introduction, I now request Dr. Ashutosh Tiwari, sir, to go ahead with his presentation.
Thank you, sir. Thank you, sir, for the introduction. Good evening to everyone. Today, as we are celebrating World Stroke Day, Joshi sir and Deshmukh sir has already covered the various reasons why patients develop stroke and how it can be prevented. Despite all these suggestions and motivating and very apt discussion, despite all measures, if you develop a stroke, still the story is not over. And we are having many options with which patient can be treated and can resume to the maximum functional status. For that, we have to remain aware about the treatment options, identifying the symptoms, reaching within the time to avail that particular treatment option, because the treatment of a stroke is very time sensitive. So we have to remain aware to many things in cases of stroke. Sir, next slide, please. So we have to remain aware to the symptoms and signs of a stroke. As Joshi sir has discussed, I will just give a brief in next slide. We have to remain aware to the timeline in the management of a stroke. 4.5 hours, 6 hours, and 24 hours, and beyond that. We have to remain aware to the treatment modalities available for stroke care, which was not present 10 years back. But the treatment options now has quite changed. And I will say a drastic change has came into the treatment options for the stroke patients. Despite those options, these options are not available or distributed equally throughout the world or our country. So we have to remain aware to the facilities available in your vicinity for stroke care. Because it is time sensitive, you should be knowing beforehand where I can reach and can avail these facilities. After this, we have to remain aware that the complications of a stroke can be managed very well, and we have developed many options for the management of complications of a stroke as we have gone forward in the area of treatment of stroke. After this, even if there is residual weakness or symptoms, there are many post-stroke conditions. There are modalities with which patient can cope with those symptoms or signs or the deficits. So we have to remain aware that the treatment options for those conditions are also available. All these things focusing on patients, we have to remain aware that in these cases, caregivers can develop burnout, and we have to remain aware to the caregiver burden in cases of stroke patients. Next, sir. So as Joshi sir told, be fast. Be fast when you identify that there is sudden onset difficulty in balance, sudden onset balance dysfunction. There is sudden onset vision loss. There is sudden onset diplopia. There is sudden onset facial weakness. There is sudden onset weakness of upper limb or lower limb. There is sudden onset speech abnormality. The key word here is sudden. If it is sudden, then be fast. You have to contact emergency. You have to contact the facility where stroke, thrombolysis, thrombectomy, or stroke care is available. Next. Because your neuron cells are dying, you have to be fast. Per second, you are losing 32,000 brain cells, or 8.7 hours aging is being added in your life. And if not treated, per stroke can contribute to aging of 36 years. Next, so we have to be fast. Next slide. Before going to the options available for treatment of stroke, just I will give a brief about the types of stroke. Stroke can be arterial or venous. In arterial, it can be infarct. Next, or it can be bleed. It can be intraparenchymal, or it can be SH, or it can be extradural hemorrhage. In venous, next, it can be CVT, cerebral venous thrombosis, which can have infarct with bleed, or it can be next subdural hematoma. Next, subdural hematoma. Apart from this classification of arterial and venous stroke, I would like to emphasize that few patients might have quick improvement in their symptoms, and patient will think of that something has happened bad and now it has improved. No, it was a sign that patient is going to develop a big stroke within 24 hours or near future. This was an opportunity to get treated and to prevent the bigger stroke, and which is known as TIA, transient ischemic attack. Counterpart of this is sentinel bleed. In cases of sentinel bleed, prior to larger bleed, there will be very small bleed, which will lead to transient ischemic attack like symptoms, which will improve over 30 or 60 minutes or within 24 hours, and patient will be treated as he has improved. But no, this was a sign and opportunity. Even larger stroke or other type of a stroke should be considered an opportunity, as Deshmukh sir already has discussed that cardiovascular comorbidity and this cerebrovascular comorbidity simultaneously exist in same patient. So stroke can be an opportunity to prevent MI, and MI can be an opportunity to prevent stroke. We have to remain aware. This is not only stroke, this is not only MI. The same risk factor plays role in both. So whichever is occurring first, we have to identify the causes, control the risk factor, and we can prevent many of the stroke, many of the MI. Next. So these were the types of stroke, and predominantly we will discuss first most of the options which are available for ischemic stroke. So if you have identified, you have been fast, really, and after being fast, you have reached to the facility within 4.5 hours, you have the options to avail, that is thrombolysis, IV thrombolysis by L-tiplase or tinictiplase. At present, ideal door to needle time is 60 minutes. It means within 1 hour of symptom onset, you should receive this treatment, which is very, very difficult in our scenario. But still, till 4.5 hour, you can avail this option. Next. Next slide, please. Up to 6 hours, in some cases 4.5 to 6 hour window, you can avail thrombolysis in selected cases where the dead tissue is less and the salvageable tissue is larger, but that depends on the individual case basis. But still, up to 6 hours, you can avail the treatment option of thrombectomy, where the clot is removed from the artery, like in MI cases. It has been extended, the duration has been extended up to 24 hours in selected cases where the large vessel occlusion is there. And this has been a game changer, but this facility requires expertise and some technical expertise and larger facility. So it is available at few centers in India, but we have to remain aware to those centers and if we can reach within 24 hours there and the candidate is eligible for the thrombectomy, we can avail this option of being treated with endovascular treatment. Next option, next slide. Sometime we have to combine the thrombolysis with thrombectomy, mechanical thrombectomy. After mechanical thrombectomy, the results are very good. And almost 50% of patients can resume to the normal pre-stroke level. At present in developed countries, there is something called bridging therapy, where emergency medical van is placed in the vicinity and it reaches on the call, does a CT scan to rule out bleed and start thrombolysis on the way while the van is reaching to the thrombectomy center. So this is the future which we can develop in our country also, but at present it is difficult. Next. So why this timeline is so important? Why we have to take care of this? As you can see, number needed to treat is very high when the medical therapy is offered to the patient. It ranges from 60 to 50 to 150 patients. It reduces further if the thrombolysis is done within 1 or 1.5 hour, and it reduces to 3 to 4. In thrombectomy, it further reduces to 2 to 3. So that is why we have to become sensitive and aware to the options available for the treatment of stroke. Next slide. Now coming to the complication in stroke patients, many complications patients develop because of altered sensorium and bed-bound status. Pneumonia, deep vein thrombosis, and bed sores are the most common, which can be managed very easily and it can be prevented with best standard care for stroke patients. Other comorbidity related complications can be managed easily, and some treatment related complications however are there, like thrombolysis can cause bleed, and which is a complication in around 7 to 8% of patients, in which 50% can be managed with some morbidity and around 3.5% are difficult to say. But this is a very small number compared to the benefit we are getting after thrombolysis and thrombectomy. Stroke related complications, as I told, patient can develop while depending on the timeline when the patient is presenting. If the patient is presenting after 24 hours, patient might develop increase in edema in brain in between 3rd to 5th or 7th day. Next slide, please. Where we can need surgical management. Next slide. So we perform decompressive surgery. We can see the CT scan of brain of a stroke patient. Next slide. Next. Where in the last CT scan, we are seeing that in fact edema has increased and there is no space for brain to expand further. So in these cases, next, surgery, decompressive surgery can give space to the brain and can prevent herniation. And after few days of this, brain starts shrinking and we can prevent herniation as well as other complications of a stroke. And the outcome is not very bad at good centers where the infections and secondary complications are taken care of. This decompressive surgery has given wonderful results in cases of venous thrombosis, which is more common in adult population, and there is less space for the brain to expand because there is no atrophy. Next. Now, after discussing ischemic stroke, I would like to tell you about the options available in the hemorrhagic stroke. Contrary to world population, hemorrhagic stroke has been more common in Indian population, probably because of the same reason what Deshmukh sir was telling, uncontrolled hypertension and other risk factors, or some specific features associated with Asian population. So in developed countries, the contribution of bleed is said to be 15 to 20%, but in our country it is ranging somewhere between 30 to 40% in Indian studies. Next. So recent discovery of some features of hematoma expansion and rebleed in hemorrhage patients has given us the opportunity that if we control blood pressure, only single measure, if we control the blood pressure within time, the outcome is quite different compared to what it has been earlier. In hemorrhage patients, we have to rule out etiological causes like in ischemic stroke, and the treatment will depend on the causes. But for primary hypertensive bleed, the most important thing to do is control blood pressure. Next. Next. So this CT scan is showing bleed in smaller bleed in first one, and after 6.5 hours in next CT scan, it has become larger, which is showing hematoma expansion or rebleed, which can be prevented by controlling blood pressure. Next slide, please. But controlling blood pressure is double-edged sword. In hemorrhage patient, there is increased ICP, so we need more cerebral perfusion pressure, and decreasing blood pressure. Next. Decreasing blood pressure might reduce cerebral perfusion pressure, leading to ischemia. So we have to find a balance. Next. So many questions arise at this point, and this has been answered by many trials. Next. Next slide. So many trials have at least proven that there is no risk in lowering BP. It is safe and feasible to lower BP. What we have to take care is, next slide, please. We can use these medications. Next. So AHA guideline says we have to ensure that continuous, smooth and sustained control of blood pressure should be there, avoiding peaks and large variability in systolic blood pressure. This simple measurement can change the morbidity and mortality in cases of hemorrhage patients. And it can be done as early as within 2 hours of ICH onset, and we can reach the target within 1 hour, and it can be beneficial to reduce the risk of hematoma expansion. In addition to this single intervention, many microsurgical techniques, next slide, has been shown to be beneficial. Minimal invasive surgeries has been shown to be beneficial in selected cases of hemorrhage. Still, we have to go a long way in this area of intervention in hemorrhage patients, but definitely for ischemic stroke patients, we are having many options than before. Next. So we are having basket of interventions for the management of stroke, be it ischemic or hemorrhagic. We have to use judiciously, but first we have to reach on time to avail those options. So on this World Stroke Day, just note down simple 2 things. Do you have stroke care facilities in your vicinity? Have the number and name of that center in case of emergency. Advise to others and keep it for yourself. And that's all about this World Stroke Day. Thank you, everyone.
Thank you, Dr. Ashutosh sir, for addressing our audience. We have been putting requests to everyone for submitting their questions in the YouTube chat box. but it seems our audience has understood the entire discussion by two of our experts. So there are no questions in the chat box at the end of our two expert session. So I'll take this opportunity to thank you, Executive Director of Institute of Medical Sciences Nagpur, Professor Prashant P. Joshi sir, for giving us an encouragement to organize such event on occasion of World Stroke Day, and to our beloved experts, Professor Deshmukh sir from All India Institute of Medical Sciences Nagpur from the Department of Community Medicine, for highlighting and putting up the accelerating hypertension management at all levels of care. The second expert, Dr. Ashutosh Tiwari sir, for briefly telling our participants about the management of stroke and how it can be the importance of time in management of stroke. So with this, I thank you all for attending this webinar on occasion of World Stroke Day 2024. And we expect that you would be submitting your feedbacks on the would be sent to you on your email to all the registered participants. And I also wish to tell you that your e-certificates would be sent to you in couple of days. With this, we are thanking you from All India Institute of Medical Sciences Nagpur. Thank you very much.